would like to welcome you and thank you for joining us for today's CMEO briefcase entitled Identifying Patients at Risk of CKD in Pharmacy Settings. Today's program is supported by an educational grant from Bayer Pharmaceuticals. And again, I'm Dr. Dhiren Patel, an adjunct associate professor of pharmacy practice at the Mass College of Pharmacy and an endocrine clinical pharmacy specialist in Boston, Massachusetts. With me today, I have Dr. Diana Isaacs, endocrine clinical pharmacy specialist, CGM and remote monitoring program coordinator, and the co-director of the Center of Excellence for Endocrine Disorders in Pregnancy at the Cleveland Clinic Endocrinology and Metabolism Institute in Cleveland, Ohio. Welcome, Dr. Isaacs.
Great, thanks so much for having me.
So today what we're going to go through is to show you how pharmacists in different settings can have a significant impact on using guideline recommended screening for early diagnosis of CKD patients with type 2 diabetes. We know in various different settings, the role of the pharmacist is going to be very different. And so what we're going to do is walk you through 3 cases in different settings to show you how easy it is and how easy it is to incorporate some of these guideline recommended screenings in this patient population. So we're going to jump into a patient case, and our first patient case here is Mr. Shah. Diana, why don't you tell us a little bit about this patient?
Sure. So Mr. Shah is flagged for medication therapy management services. So the retail pharmacist takes note of his profile. He's a 61-year-old Asian male, and he has type 2 diabetes. He also has hypertension and depression. In terms of medications, he's taking lisinopril 40 milligrams daily, and you take note that he is 8 days late in filling his prescription. He also takes citalopram 20 milligrams daily, metformin 1,000 milligrams twice daily, and then semaglutide 7 milligrams daily. And then in terms of, 8 months ago on the last MTM call, his blood pressure was ranging from 130 to 140 over 80 to 90s. His BMI was 39, and then fasting blood glucose was 98.
Excellent. So why don't we continue with the patient, and if you can go through some of the additional information that you have here on Mr. Shah.
Oh, sure. So in terms of kind of how the conversation transpires, so the retail pharmacist says, "Hi, Mr. Shah, I want to reach out to you today to check on your medication. I see that the lisinopril that you're taking for your blood pressure is overdue for a refill. Are you still taking this medicine?" So we can see here, it's really great to take note when a person is late for their refill. And Mr. Shah says, I'm still taking it, but when visiting the doctor last month, she said that my levels were like a healthy 20-year-old. So I thought, I didn't really need to continue taking it based on, my blood pressure, or I could just take it maybe a few times a week instead of all the time. So the retail pharmacist says, "Well, glad to hear that your blood pressure is in normal range. This means the lisinopril is working. And do you have a few minutes to discuss this a little bit more?" And Mr. Shah says, "Sure."
Excellent. And so even before we discuss this case, what I want to do is do a quick polling question for our audience. And the question that I have, and then we'll go back to the case here, is in addition to reinforcing the importance of taking his lisinopril daily for blood pressure and cardiovascular benefit, what about Mr. Shah is the most compelling factor that indicates he is at risk of developing CKD? Is it A, he is 8 days late refilling his lisinopril? B, his ethnicity is Asian? C, he has type 2 diabetes? D, his dose of metformin is high? Or E, I don't know. So go ahead and key in your answers. So let's talk about Mr. Shah, and I'm sure there's many other patients that you see that are going to fit the profile of Mr. Shah. And if you think about it in a retail setting, as you just witnessed in this case, you have a lot of patients that have a diagnosis of diabetes, diagnosis of hypertension, and it's very evident to tell who those patients are. And so in this situation, you saw that the pharmacist asked Mr. Shah for some additional time, And one of the reasons is if we look at the patients that have type 2 diabetes and their risk of CKD, about 40% of this patient population goes on to develop CKD, but only 10% of these patients that know that they have CKD. And so that's where, pharmacists on the front lines, whether they be in a retail setting, we'll see later on in the segments, whether it be in the hospital setting or even an ambulatory care setting that, Dr. Isaacs is in, is that there is a very easy role that the pharmacist can play. And our goal, here is that CKD typically develops, 10 years after onset of the disease. And so the sooner we act, the sooner we take action, we can start, catching this much earlier. And, pharmacists are great folks. Again, having these discussions, you saw, an example here in which the patient was late in a refill. There was something that was pretty evident from the patient's, medication list that the patient was at risk. And so I think it's a really important area. And so Dr. Isaacs, the question here is, what else do you see here? And what are some things that you can share for our pharmacists that are on the front lines in a retail setting?
Yeah, well, I think you shared some really good statistics. And the fact that, chronic kidney disease develops typically, 10 years or later after a person has been diagnosed with type 2 diabetes, I think is a really important point. And that means that anyone with long-standing type 2 diabetes is really at risk of chronic kidney disease. And on top of that, many people who have type 2 diabetes have actually had it for years and didn't even realize it, thus putting their kidneys at even increased risk. So I think that is an important thing to take note, how long your patients have had that for as well. Also, their level of glucose management. So unfortunately, we do know kind of the higher A1Cs, the higher glucose levels, does put someone's kidneys at greater risk. And so that's something that pharmacists can be asking about, asking to take a look at glucose levels and making sure that our patients know what the glucose targets are, I think is really important. And then pharmacists, we are known for monitoring kidney function. I mean, that is how we adjust medications. We love to calculate the creatinine clearance. And so that's something we can make sure our patients are up to date with their labs, because that's going to be the best way that we can really monitor also to make sure, patients are being screened for their kidney function.
Yeah, no, that makes a lot of sense. And, something that I hear from my colleagues that are in a, retail scenario, and it hasn't been an easy year and a half, maybe a little bit more, they, are doing their day job. In addition, they're doing these, services such as MTM service. Now we have COVID vaccinations, but, I think the retail landscape is also changing as you see the CVS and Walgreens, CVS, you have these health hubs. I know we have one near us and you may have one there, or with the Walgreens, you're seeing additional primary care clinics that are setting up next to them. And so I think even just the trend and where the big box stores, and even obviously, you have the independent pharmacies, they're doing more of these type of services that you just mentioned of, checking a patient's blood pressure, opening up their log book. You shared a few of those, but, I think if you could maybe just talk through of how easy of an effort would it be here to have that, conversation regarding, hey, have you gotten this checked, right? So maybe if you can talk a little bit about that, because it seems like every year we ask our folks and our colleagues on the front lines to do a little bit more.
Yeah, so you're right. We don't want this to be burdensome. We don't want to add, we know time is so precious, right? So I think in the visit, it's just a matter of just asking, have you been to your doctor recently? Have you had labs done recently? Because what we know is pharmacists are the most accessible healthcare professionals. And many patients are only seeing their pharmacists. And especially like in these times of COVID, when there's been a lot of hesitancy to go to the doctor's office and, see people if you don't have to. And so I think just asking the question can go a long way and really doesn't have to add so much to the visit. Also, for any pharmacies that are taking learners, that have students on rotation, that have technicians there, really utilizing them to maybe provide some additional, just even education about glucose targets, even if it's like a pamphlet. Because I find like some of my patients are just not aware. No one's ever even told them what their glucose goals are. And so just like these little things, it does not have to be so time intensive.
Absolutely. Thank you so much for your insights there. And speaking of COVID, let's switch gears and talk about our next patient, Miss Johnson, who's being discharged. And why don't you walk us through Miss Johnson here?
Yeah, sure. So Miss Johnson is a 65-year-old woman, and she was actually admitted to the hospital with COVID. And so, she was seen by the transitions of care pharmacist in the hospital, getting ready for discharge. And she was noted to have type 2 diabetes for 18 years. And her home medications include losartan, 50 milligrams daily, insulin glargine, 40 units daily. And then she takes insulin aspart, 10 units 3 times a day before meals, metformin 1,000 milligrams twice daily, and then she's also taking a multivitamin. And in terms of, she had some different labs that were done when she was in the hospital, and the pharmacist takes note that just some of the labs, many were in range, but takes note that her most recent A1C is 7.4%, her BMI is 36, and then her GFR is 58. She did not have an albumin to creatinine ratio that was done recently, but there was one in the chart from about a year ago, and that showed that there was 37.
Excellent. Thank you so much. And what we'll do is let's go through another question and then we'll come back to Miss Johnson. So the question for the audience is, what guideline recommended screening should the transitions of care pharmacist recommend for Miss Johnson to receive prior to her post-discharge outpatient follow-up telehealth call? Is it A, a repeat COVID test, B, a urine albumin to creatinine ratio test, C, A1C, or D, I don't know? So go ahead and key in your answers. Excellent. So what we'll do is, I know we alluded to this in the beginning of the presentation, is with many chronic conditions, I think pharmacists are pretty well aware of, how often a patient with diabetes should get their A1C checked, or how often you should check a blood pressure. But sometimes, what the guidelines say regarding screening might not always be top of mind. And so we'll do a quick refresher of the patient populations that you would be encountering, and regardless of what setting you are, whether they be retail, hospital, direct patient care, is that the annual screening for urine albumin and eGFR should take place and be screened in all patients with type 2 diabetes. And the way that we go about doing that is that you want to confirm this on 2 separate occasions that are greater than 3 months apart. And basically, if you get 2 abnormal readings, that would constitute a diagnosis. And what you see here are basically the 3 different levels and interpreting these eGFR results, which I'm going to get into more detail on the next slide. So when you think about, eGFR and UACR, sometimes it's a bit confused because many of us are used to eGFR because, like Dr. Isaacs mentioned, we're dosing drugs off of it. It's something that we have access to within our charts. And a good way to kind of remember this is that eGFR is a test of kidney function, while UACR is a test of kidney damage. And it's really important that we collect both because it gives us that prognostic framework that we need to understand CKD. And so what you see here on this slide are your stages of CKD, and then you can see stratified based on the patient's eGFR. And so again, that's why we need both. And that helps us to figure out, where that patient is classified, and then also what action we need to take off of that. So let's go back to Miss Johnson, knowing, some of the pieces that we just covered here and what we know. Dr. Isaacs, why don't you take us through the follow-up here?
Yeah, so we know, she hasn't had that albumin to creatinine ratio checked in over a year. So, and that would be a screening recommendation to have at least done annually. So, Mrs. Johnson made an appointment to have a spot urine albumin to creatinine ratio test. And then she has an ambulatory healthcare visit scheduled follow up. So she has a telehealth visit, and that's very typical when someone's discharged from the hospital, especially, post COVID, that we try to follow up with them in 3 to 7 days after their hospitalization to make sure everything is going okay. And so the new value for her urine albumin to creatinine ratio is recorded in the electronic medical record and really facilitates that post follow-up with the pharmacist to have all of that data and be ready for that telehealth visit.
Excellent. Dr. Isaacs, I have a question for you on the spot urine ACR test that you just mentioned. And I think I've been guilty of this in clinic where, we tell the patients that your lab's are ready, go down to the lab. And sometimes, they're just associating whatever they do from a blood work standpoint, but they sometimes don't recognize that you've also put that in. And then all of a sudden they're like, well, why am I, peeing into a cup, right? So what do you do, or how do you remind your patients that, you're doing this, and what does that education piece look like? Because I have a lot of patients in settings that I've worked in the past, like the VA setting, where patients are, why are you checking my urine, right? And for whatever reason that might be, but how do you explain it to your patients regarding that spot urine?
Yeah, I mean, I just try to give them a heads up that we're going to be checking your urine and we're going to be checking your blood. I mean, I
Mhm.
think the good part about it is you don't need to fast for this test. So at least it's more convenient. It can be done, anytime during the day. But I find if you just give them a heads up, just say, oh, there's certain, we're looking at we want to look at your kidney function. A lot of times we get a urinalysis too, so I think if you just give them that heads up, then they're not surprised why they have to pee in a cup.
Yeah. Yeah. And that's what I found as well, is like, if you just say, hey, for diabetes, hypertension, we just want to make sure that, you're not leaking any protein in the urine. We do this once a year because it's not a common test. And sometimes, as you know, it's not routinely done. And so sometimes they've never done it, even though they're like, well, I've had diabetes for 10 years. I've never done that. Right. And so I think that's really important to kind of put that bug in their ear so they're not surprised when they get down to the lab and it avoids a phone call and a page.
Yeah, that is a great point. Yeah.
So let's do this. Let's take a look at the post-discharge telehealth call. So we're going to bring it up here and show you how that call went.
Hi, Mrs. Johnson. My name is Diana Isaacs, and I'm a clinical pharmacist that follows up virtually with people after discharge from the hospital. How are you doing today?
I'm doing good. I'm much
Oh,
better.
well, that's great to hear. So I'm looking at the chart. It looks like you were in the hospital with COVID, and I see that you were discharged about 7 days ago. Is that right?
That's correct.
Okay, well, I'm glad to hear that you're doing better. If it's okay with you, I just want to take a few minutes to go through your medications and just see if we can come up with any options to help you. Okay?
Sounds good.
All right. So I show here that for your diabetes that you're taking insulin glargine 40 units daily. Is that
Correct.
correct?
Correct.
Okay. And then it looks like insulin aspart 10 units at meals.
Correct.
Okay. And how many times a day do you typically take the aspart?
3 times
Okay,
with
perfect.
meals.
Perfect. And then it looks like metformin 1,000 milligrams twice daily.
That's right.
Okay. And I see since you were discharged, we ran some labs on you, and it looks like we got a test called your albumin to creatinine ratio, which is a really good marker of how your kidney's functioning. And so I wanted to explore some options that we could use to really help with your kidney function. I wanted to first ask though, if you've ever been on a medication class called SGLT2 inhibitors.
Yes, I have been on Farxiga and Jardians.
Okay, and what was your experience? Do you remember why you stopped
Oh,
taking
it was
those?
bad. I had urinary tract infections that were so bad that I would never go on that medication again.
Oh gosh, I'm so sorry to hear that. Well, we actually have some newer options that may really be able to help you. Is it okay if we spend some time to talk about this newer option?
Sure, I'd love to hear it.
All right, great, thanks.
Mm-hmm.
So there's a couple of things that stood out in that telehealth visit call. Dr. Isaacs, can you walk us through what stood out to you there?
Yeah. So, in that visit, I think we learned a few things. So one, I was definitely able to kind of confirm the medications and confirm the glucose management and everything. We were able to get that follow-up urinary albumin to creatinine ratio and confirm that. And that was very, very helpful to better understand the kidney function. And I learned really in the conversation with Mrs. Johnson that she previously had been prescribed an SGLT2 inhibitor, which we know, has benefits for the kidney in addition to benefits on glucose levels. But she actually tried two different SGLT2 inhibitors and just really had bad urinary tract infections that made it really challenging for her to continue. And we know that unfortunately can be a very common side effect of those agents. And I confirmed, she's had longstanding diabetes. So it's very common, over the lifespan, having diabetes for many years, that the kidneys are impacted. In fact, we know that even with people who maintain A1C levels close to 7%, there's still, unfortunately, there still can be some damage to the kidneys over time. In addition to that, I had her lab values in front of me, and I saw that her glucose value was also a little bit elevated too, showing that she probably also may benefit from some additional glucose management as well. So kind of learned all that through that follow-up.
Yeah, no, excellent. So, that explains, I think, her elevated glucose. And I think she, the fact that she was maybe on an SGLT2 inhibitor and is no longer on it could be a reason. But again, that's something that you'd have to have a longer discussion to kind of see kind of what's going on there. And that's something that obviously, we can follow up with. So you mentioned, the genital infections. And again, SGLT2s are, becoming increasingly popular because of, the additional benefits that they have beyond glucose. We know from, these pleiotropic effects from heart failure to CKD, cardiovascular benefit. But one thing that we do have to balance is this incidence of genital infections that we see, especially in patients with type 2 diabetes. Could you kind of walk us through that data, but then also kind of how you've handled it? You've mentioned she's been on two other ones. How do you deal with it? How are you having these conversations? And what does the data show us?
Yeah, so I mean, the data shows that unfortunately, these genital infections are somewhat common. Based on the various trials, they can range from, I don't know, around 5% in some of the trials. We see some of them are even higher, as high as 13% of patients experiencing some type of infection. A lot of times in practice, if it's just one, we try to treat it. And then we try to continue, we try to still use the agent. Unfortunately, I do see that there are some people that are just really prone to these recurrent infections. It seems like some people just, they're more likely to have them, and then the SGLT2 inhibitor just kind of throws them over the edge. And so, yeah, it's like, well, we could keep continuing the agent, but they're really uncomfortable, and we're just constantly having to treat and use antibiotics. And it's not at all an ideal situation. So even though, yes, this class of drugs has many benefits, and we try to use it when we can, it's unfortunately, it's just not for everyone. And so we have to look at other therapies with some patients.
Yeah, absolutely. And again, everyone has their own best practices, but I've adopted two strikes and you're out.
Oh, sorry. I think in this situation, she even tried two different SGLT2 inhibitors. It's like she gave it a good try, like we don't have to keep throwing every single one at her. Yeah.
Yeah, no, that's definitely the case. And it impacts kind of, sometimes your rapport with the patients and, persistency in them coming back. So it's definitely a delicate tightrope that we have to walk. But what I want to do is go through another audience response question. Here, the question is, which of the following is accurate when using EGFR and UACR to assess patients at risk for CKD? Is it A, UACR and EGFR have an inverse relationship? B, eGFR is a better predictor of kidney damage than UACR. Urine creatinine is needed to calculate eGFR as option C. Option D is UACR, eGFR help determine CKD stage, or E, I don't know. So go ahead and key in your answers. And now let's go back to the case of Miss Johnson and put her on the CKD heat map so that we have a better idea of where we need to go next with her. So here, you can see that we're only looking at a slightly decreased eGFR, which here is at 58. We would have stages her in the yellow, and so that's a 3A category, but since Mrs. Johnson didn't have a UACR and the results were elevated slightly in chart 1, which was a year ago, around 37, I think that's what you said, Dr. Isaacs, and now it's elevated to 275, we know that that CKD is in the orange. So this is a great example why you need both and what we talked about, because the eGFR alone won't tell us the whole story and you don't have a complete picture. And that picture can change very quickly, right? From a year ago, where it was 37 to 275, where she falls on to the heat map is obviously going to change. And so, Dr. Isaacs, what would you do about her plan here? I mean, there's a lot to do, but where do we start for Miss Johnson?
Yeah, so I think there's definitely a few things that we can do. I am concerned about her kidney function and the fact that it is declining. It appears to be declining. And so I would want to do whatever we can to protect those kidneys. And we know, of course, good blood pressure management, glycemic management, but also now, really for the first time ever, we have a therapy specifically targeted for people with type 2 diabetes to help protect their kidneys, and that is finerenone. So that's what I was getting ready to tell her about and share that. And hopefully through shared decision making, get ready to start that agent. In terms of glucose management, I would not at this point, retry the SGLT2 inhibitor, but I would look at other agents that can really help benefit the cardiovascular risk and also may have some additional kidney benefits. And that would be the GLP-1 agonist category as well. And also the thing is, if we're looking at evidence-based diabetes guidelines, they really recommend anyway, the first injectable should be a GLP-1 agonist even before you go to insulin. And so for all those reasons, I think that would really be a great approach. And it's okay that she's already on mealtime insulin. We can back off of it. We can adjust her regimen, but that would really be like my kind of go-to plan in this situation.
Yeah, and I think those are both excellent points, and maybe we'll dissect them a little bit more. I think, what you mentioned with finerenone, I know we reviewed this in our larger segment earlier, but I think this is a non-steroidal MRA, and so we don't have the androgenic side effects that we're used to maybe within a eplerenone or spironolactone, which I know is something that we deal with a lot whenever we are using those steroidal-based MRAs. But also that the studies that were done here were done on top of standard of care. So this is, patients that were on an ACE or an ARB in which this additional benefit was seen. And so I think in this situation, just to keeping that in mind, that's how the study design was, and it, mimics what we're doing here, but also what we would be doing in practice. And so it's not, if a patient's on an ACE or an ARB, then they don't need any additional protection, is one point. And the other point I'll make here is you mentioned the GLP-1. And so I want to clarify something there. Is that there's emerging evidence with them. They don't have anything, obviously, from a labeled indication, such as some of the SGLT2, but, it's another step in the right direction. So now you potentially have 2 agents that are pulling for her, and hoping we can kind of slow down the disease progression. And the other benefit that you would have in both of those cases with the finerenone as well as the GLP-1 is the CV benefit. And we've talked in the larger segment in the presentation of the increased risk this patient population is at from a CV event. So I think you're helping with the CKD, you're helping with the CV, and so all around you're getting some additional protection just beyond thinking about the CKD.
Yeah, those are all great points. Absolutely.
So let's go back and revisit the audience response questions and see what our brief cases have taught you all today. So we're going to go back and start with the first one that we had, and you guys might remember him, Mr. Shah. So in addition to reinforcing the importance of taking his lisinopril daily for blood pressure and cardiovascular benefit, what about Mr. Shah is the most compelling factor that indicates he is at risk of developing CKD? So you see your options that were listed here, and the correct answer and the best option here would be C. He has type 2 diabetes. The next question that we had was, what guideline recommended screening should the transition of care pharmacist recommend for Ms. Johnson to receive prior to her post-discharge outpatient telehealth call? And so those are your options that you had to select from. And the best answer here is B. So Dr. Isaacs, can you explain to us why this would be the best option?
Yeah, so in this case, the last urine albumin to creatinine ratio was done over a year ago, and we want to be checking that at least annually. In terms of the other choices, A1C, typically we only collecting that every 3 months. So if she had a recent one, we wouldn't need to recheck that at this point.
Excellent. Thank you so much. And our last question is, which of the following is accurate when using eGFR and UACR to assess patients at risk for CKD? And those were your options there. And the best answer here is D. UACR and eGFR help determine CKD stage. And I think we've mentioned it multiple times throughout the presentation, is we need both. And again, it helps with that prognostic framework that we talked about. You saw in Ms. Johnson's case where both are important to help them then plot the patient on the heat map. And so the correct answer here would be D. So what I want to do here is kind of tie together, what we've discussed. And, this has been a little bit of a different type of education for pharmacists. But I think, one thing that you'll be able to walk away from is, regardless of which setting you're practicing in, whether it's retail, hospital, ambulatory care, I hope through the examples that we've shared here with some of the patient cases is that it gives you confidence in knowing that, early detection of CKD should be on all of our radars, along with also being mindful of what their, CV risk is. And we showed throughout the presentations today that there are a lot of easy ways to do this. You saw the transition of care. Pharmacists, recommend that at discharge, arrange for that telehealth visit. In a retail setting, it's a simple discussion. Hey, have you had this test before? If not, talk to your doctor about it. And so it's recommended that at a minimum that the annual screening of this happen. And we're really good of, making sure and we're reminding our patients of their annual flu shots, checking their feet daily, getting a yearly eye exam. And so this is one of those other things that you just add to that mix. As when I go down on any patient, I'm just thinking of all the preventative things that I need, and then it just becomes incorporated into that checklist. And I find that to be the easiest way to translate kind of what you're seeing and learning here into practice. And then the other thing is, I think the sooner we know, the sooner we can do something about it, right? And so I think here, you saw different drug classes, you have multimodal options, and the goal is, individualizing this to the patient. You saw in Mrs. Johnson's case where you have a medication that's FDA approved, regardless of diabetes status, in which the patient was not able to tolerate, right? And so it's really important to understand all of the tools within your toolbox and knowing when to reach for which tool. And I think hopefully you were able to appreciate that here. And then knowing that, the last innovation that we had in this space was, I think losartan about 20 years ago. Since then, we have SGLT2 inhibitors. We talked about finerenone, which is a non-steroidal MRA. And we talked a little bit about emerging data that the GLPs are coming up with. And I think this is a great thing for our patients, because none of our patients ever just have hypertension, or they never just have diabetes. They have, chronic conditions or polychronic conditions where they have CKD and something else. And so hopefully these new therapies are helping, obviously with CKD, like we saw in finerenone's case, but also the CV benefit that it also confers for your patients. So I want to thank Dr. Isaacs for joining me here this evening and sharing her best practices. I do also want to remind the audience here that today's CMEO briefcase is the first in a series of case-based activities. So be sure to check out some of the other series to dive further into the co-management strategies and what counseling for patients with type 2 diabetes and CKD would look like. Also, there is a virtual education hub that CME Outfitters offers. And Dr. Isaacs, you mentioned, pamphlets, resources. So here we have some resources for patients. I want to just thank you all for taking the time this evening to learn a little bit more, especially as it relates to the guideline-based screening recommendations as it relates to chronic kidney disease. So thank you again for your time and attention, and have a great evening.